So it's really a pleasure to have here my good friend Alessandro Vinciarelli. He's always been let's say, a door opener in some way. So he's been working from the time I know him on social signal processing. We just had a chat, so he's been already in Glasgow for 14 years. Well, I was always inspired by his work and his results. And today he's going to talk about AI for mental health. And well, he has a lot of contacts and a lot of collaborations with many institutions. And well, it's really a pleasure to have you here, Alessandro. So the floor is yours.
Thank you very much for giving me the opportunity of being here. It's really a pleasure, an honor to be giving this talk. And so we are going to talk about artificial intelligence for mental health. And first of all, we are going to introduce the topic, and in particular, how AI can play a role in mental health. We are going to see a couple of important cases, which are depression and attachment, and then at the end, a few words of conclusion. So we can start with a quick introduction, and in particular, some facts why mental health is an important issue. Globally, the total number of people with depression was estimated to exceed 300 million in 2015. 7.5% of all years live with disability in 2015, major contributor to suicide deaths, which number close to 800,000 per year. So you look at these numbers. This is a very famous report published by the World Health Organization in 2017, and it is quite a dramatic impression. It's roughly 4.4% of the population at the time that is affected by depression. And this gives you a little bit of a snapshot at a certain point in time. But you can look at this other study that says that between 2008 and 2018, prescription for antidepressant medication in the UK increased from 36 million to 70.6 million. A study of 29 countries, all of them had seen an increase in antidepressant prescription between 2000 and 2015, doubling on average. What does it mean? Well, antidepressants are used not only for depression, are in general used for a lot of other problems in mental health. This gives you an idea that not only the numbers were pretty bad at a certain point of time, but we're really talking about something that keeps growing. And the recent pandemics, COVID pandemics, has aggravated a lot the situation. So recent data is not available yet because the world was busy dealing with COVID. However, we know that this pandemic has further increased these numbers, right? So we talk about a problem that actually is quite important and keeps growing. And it is probably because of this that the Gartner Group, one of the most important strategic consulting companies, has identified the detection of mental health issues as one of the most important and one of the areas with the biggest potential in the case of artificial intelligence. Emotion AI vendors have moved into completely new areas and industries, helping organizations to create better customer experience and unlock real cost savings. Software can help doctors with the diagnosis of diseases such as depression and dementia by using voice analysis. So here you see what is interesting of the Gartner Group is that these are people that consult businesses. They try to help companies to make more profits. So when they tell you that this is an area that is going to grow, you can be sure actually that there is going to be investment, there is going to be potential in those areas, right? And when you look, when you think of the numbers we have just seen, you can understand why this happened. But what is interesting is also that the Gartner groups clearly can understand, can identify this area as an area where AI can actually have a potential of giving good result. And so we can see, we can have a look at how actually artificial intelligence at large, right, can be helpful in the case of the detection of mental health issues. So this has to do with the way clinicians work. In general, what they do is that they take people, and here we have, for example, one person that has no mental health problem, and a person that is affected by a pathology. And what clinicians typically do is that when they receive these potential patients or these patients, they ask them to do something. They apply a test, right? And because mental health is not something that leaves physiological traces, it is really an interpretation of the doctor based on the behavior of people. What they do is that in a very rigid way, in a very rigorous way, they apply clinical protocols and they ask people to do something. Answer some questions, read some text, go through some tests, etc. And what they observe is that there is a certain variance in behavior depending on your underlying condition, right? So what happens essentially is that the expectation is that when you ask people to perform the same task, if they are affected by a certain mental health pathology, in one way or the other, they should behave in a different way compared with people that are not affected by that pathology. And that's exactly what the doctors do, right? They observe this variance in observable behavior, and they try to make sense of it in terms of a diagnosis. So in terms of deciding whether the person is okay or whether the person is affected by a pathology. Now, what is the relationship of AI with this? Well, when you think about what AI does, is exactly that, right? AI essentially is something that tries to make variance partitioning. So take variance in the data and associate that variance in the data with some information of interest. So essentially it does exactly, in general, what the clinicians try to do during their clinical practice, during their observation of potential patients of mental health issues. So from this point of view, AI, or at least what we call AI nowadays in the computing community, somewhat seems to fit pretty well what clinicians do in their everyday practice, right? And that's why the computing community is making substantial efforts in order to detect mental health issue based on observable behavior, and in particular based on speech, meaning what people say and how they say it. And this is very general, but we can see a couple of examples to figure out exactly how this can work and what type of results we can get. And also we are trying to see whether this can fit in any way the clinical practice, whether this can be actually used by a doctor. And we start with depression, that, as we have seen, is probably the most common and the most devastating type of mental health issues, also in terms of numbers of people that it affects. First of all, what is depression? It is an increase in negative emotion and feelings and a reduction in positive emotion and feelings. Sounds like a very simple definition, but essentially what it means is that a person affected by depression cannot have any type of positive experience. They only have negative experiences. And that is why it has such a devastating effect. And what are the consequences, the symptoms, right? Depressed moods, loss of interest or pleasure, decreased energy, feelings of guilt or low self-worth, disturbed sleep or appetite, and poor concentration over extended periods of time. So when we talk about depression here, we are not talking about someone that maybe has a bad day or has a few days of let's say, low mood because of something happening in their life. We are really thinking of people that have this type of symptoms, this type of condition over extended periods of time, right? So can we then automatically depress this type of condition automatically using AI? And what we did was to do an experiment to take 59 people. And you can see here they're split into two groups. Roughly half are depressed people. By depressed is meant diagnose these people with depression. Another half are control people, meaning these are people that have never experienced any type of mental health issues. And you can see in this table, when we look at the distribution in terms of gender, in terms of age, and in terms of education, primary and higher stands for education, essentially, the distribution is the same. Why these three factors? Because these are factors that can affect the way people talk. And so we wanted to have roughly the distribution to be roughly the same, so that any difference that we observe is actually a difference in these people in terms of being depressed or not being depressed. And what happened is that essentially the doctors that collaborated with us applied a protocol, a typical clinical protocol, had a therapeutic interview with these people, which simply consists in posing a number of questions that are very simple, like what did you do last weekend? Tell me about the movie, a movie you watched that you liked. Tell me about something you did that you were particularly happy about, etc., etc. Right? So very simple questions about everyday life. And fundamentally, the doctor record these sessions, because after the session, they go through and they try to figure out whether the person is depressed or not. And they, through the analysis, through what people say, through the way they say it, they fundamentally make their diagnosis, whether the person is depressed or it is not depressed. Now, to give you an idea of how noisy can be this process, here you can see these people, besides going through this therapeutic interview, they were asked to fill a questionnaire, which is a very common questionnaire. It's called Beck Depression Inventory, BDI, 2, because it is the second version that was elaborated by this important psychiatrist. His name is Beck. And somewhat the idea is that people fill this questionnaire about themselves, and this should give you some kind of indication about whether they are depressed or not. And you can see in this vertical red line, what is the line, let's say, what is the score that separates people that are affected by depression to a pathological extent and the others. And you can see this very interesting thing. If you look at the control people, actually the largest majority of people are on the left side, which means are people that are not affected by depression. So the questionnaire actually reflects their condition. But if you look at what happens for depressed people, you see that it's not that clear-cut. So this type of instruments are affected by biases. Sometimes simply the depressed people are not even capable to go through the entire questionnaire because it is multiple questions. You have to put concentration and so on. So this kind of traditional instruments are a little bit ambiguous, right? And so that's why also the use of artificial intelligence, it is something that can also help to make the whole process a bit more objective. And then, you know, just to give you an idea of what was the type of recording we collected, because we recorded all these conversation, this gives you an idea of the distribution of the durations. And you can see really by naked eye that in general, control people tend to speak a bit more. There are a few exceptions in the case of depression participants that are plotted in green here. But you can see that on average, actually, to a statistically significant extent, depressed people tend to speak less. And this is well known in the literature because they have a difficulty in engaging with social interaction. And very important, we had a linguist to go through all these conversations, 60 conversations, and manually transcribing this conversation in linguistic terms, meaning that they were split into clauses, which is the smallest linguistic unit. It is one noun, one verb, and one complement, possibly with a couple of adjectives. And these clauses, these very small sentences, essentially 3 to 5 words, 1.5 to 2.5 seconds, are the analysis unit of the experiments that I'm going to present, right? And this gives you an idea of the distribution in terms of number of clauses we get for every person. You can see that we have several hundreds. Even in the case of depressed people, we have always at least 50, 60, in the smallest cases, clauses. And what we do is that fundamentally we try to analyze individually these clauses and then to see by putting together all the clauses whether we can decide whether a person is depressed or not. And of course, in this case as well, let's say control people tend to have more clauses simply because they tend to speak more. So this gives you an idea of the approach we use. On the upper part of the screen, you can see the unimodal approaches. very simple approach. Essentially, we apply a feature extraction approach that somewhat converts either the text or the audio, because we analyze paralanguage, the way people speak, and language, what people say. It converts them into a sequence of feature vectors. It passes to a bidirectional LSTM. And then you take the hidden representation resulting from that, you pass it to a softmax that estimates the posterior probability of a person being depressed or non-depressed. And then we do this for every clause, and we apply a majority vote to decide whether actually the person has to be assigned to depression or control. And then this is done unimodal, in a unimodal way, using only paralanguage or using only language, but then you can combine the two by doing something like this. Either something very simple, the sum rule is a very standard and old approach. You simply sum the posteriors that you obtain from the two modalities, and then you use that posterior to decide whether the clause corresponds to a depressed or a controlled participants. Or you take the hidden representation and either you pass to a network layer that somewhat obtains as output a joint representation, so a representation where every component is a linear combination passing through the activation units, through the activation functions of the various components of the original data, or to a gated multimodal unit, which is simply something that learns a weight and tries to give more weight to the modality more likely to give you the right answer. And this is done clause by clause, and then a majority vote that again can give us a final outcome. And these are the results that we get. Okay, in terms of accuracy, precision, recall, and F1 score, you see the first two bars in every group correspond to the unimodal approaches, and the other bars correspond to this different way of go to a multimodal approach. And let's say one indication that we get is that in general, especially in terms of accuracy and F1 score, that are the two most important metrics from an application point of view, we can see that actually the multimodal approach can help, right? Can improve. And why that happens? Because when you go to see how language and paralanguage work, you can see, for example, that language is very precise, meaning when using language, you detect a person as depressed, you can be very much confident that it is depressed, but the recall is very low, right? It loses a lot of depressed people. That in medical application is something very serious, right? It is a very bad mistake when you classify a person affected by a pathology as a healthy person, because that means that a person that needs medical attention will not get in. Vice versa, you can see that paralanguage, the way people speak, is a little bit more equilibrated in terms of precision and recall. And it is because of this difference in behavior of the two modalities that probably the combination of the two helps to increase to a statistically significant extent over the results that we get with the best modality. Right? However, let's say this is interesting for us in general, for people that do AI, more or less you stop at this point. One thing that we are trying to do is to move a little bit towards clinical practice and say, okay, can we have doctors using this type of technology? And so we added one step, which is let's try to have a confidence score. What does it mean? Let's try to measure how confident is an approach about its outcome. And what we do is something very simple, right? It's simply to take, okay, we apply a majority vote, and we see how large is that majority. One thing is that the number of clauses corresponding to the majority class is 90% of the total. One thing if it is 51%. So in both cases, we make the same decision about an individual, but in principle, if the fraction of clauses attributed to a certain class is particularly high, we can probably think that the system is a bit more confident about its decision, right? And how can we see whether this confidence score actually works? Well, fundamentally, you can do like this. What you do is that you take all your participants, your 60 participants, and you rank them according to their confidence score. And then you can see what is the accuracy if you take into account only the top scoring person, the two top scoring person, the top 3, top 5, etc., until you get to the end. So the last point of this curve simply corresponds to the accuracy that you obtain with the approach, the one that you are shown in the previous plot, right? While intermediate, you get the accuracy that you get when you consider only the top ranking people in terms, the top ranking participants in terms of confidence score. And this is interesting because you can do something like this. This is very interesting from a practical point of view. You can basically set a threshold, which is here this horizontal red line, in terms of accuracy. Here it corresponds to 90%. And you can go to see where it intercepts these various curves. And in correspondence with the interception, you get a certain number of people. So here, for example, we have for the multimodal approaches 41, 42. And you can basically take the confidence score corresponding to that position as a threshold. And so that means if I set that threshold, so I accept the outcome of the system only when the confidence score is above that particular value of confidence, then I will get an accuracy of 90%, right? So this allows you basically in this particular case to say, I can process automatically 42 people out of 60, so more than 2/3 basically, and still get the 90% accuracy, right? And this is the big help that AI can give in terms of mental health, because that means that doctors can basically get rid of 2/3 of their times. Because with the numbers we have seen at the beginning, one very important thing that engineering can do here, computing can do here, is to reduce the burden of the doctors, right? Now, we set here a threshold of 90% accuracy, right? Which in general, it's a very high value. Still, we might wonder, but still we are going to lose, we are going to make 10% of mistakes, right? Which means we are still going to lose a number of depressed patients, right? So is that good? Is that bad? Well, here we have the accuracy we obtain with the different unimodal language, unimodal paralanguage, multimodal joint representation, gated multimodal unit, and some rule. You can see the different performances we get. And the point is, compared to the accuracy of a general practitioner, which is the very first doctor you go to see when you suspect you have depression. So the general practitioner, at least in the Anglo-Saxon world, is the doctor that is not a specialist in anything, but you go to see that doctor, and the role of such a doctor is to dispatch you potentially to a specialist, right? So it's a person that should figure out you are potentially affected by depression and send you to a specialist, to a psychiatrist. So what is the performance of GPs in detecting depression of these general practitioners? Now, the literature after a wide analysis of how these GPs do in different systems all over the world. And interestingly enough, you can see these two red lines, right? On average, they range between something like 57, 58 and 74, 75, right? Something like this. So fundamentally, you can see that even our approaches without confidence score, even the unimodal approaches that do not go as well as the approaches, as the multimodal approaches, still they compare very well with the average GP in various countries. So from this point of view, even like this, they are not perfect. However, they will improve already substantially with respect to what an average GP can do. Of course, provided these results can generalize to all the other data, and that this type of technologies can be put in a condition to work appropriately in real-world conditions. And then we can see, now this depression is a very important case, right? We can see whether we can use a similar approach or similar methodologies in order to deal with another type of mental health issues. Because someone can say, okay, depression is an important case. It is also something that leaves heavy traces in behavior. Can we go for something that is a little bit more subtle, right? And here we are going to see another problem, which is a little bit subtler, more difficult to detect, which is attachment, which is actually not really a pathology or not necessarily a pathology. It is something that has to do with all of us. Each one of us has an attachment condition. And it has to do with the perception of our relationship with parents. And we're going to see why this is important, right? So, in particular, what is important is to measure, is to detect potential attachment issues when you are a child, right? And essentially, a child can have two attachment conditions, right? Every child has some kind of perception of what is the relationship with the parents, which essentially means, are the parents capable to satisfy, to meet the emotional and relational needs of the child? Notice that this has nothing to do with being or not being a good parent. You can be an excellent parent, very good willing, however, your children might not be capable to express their needs properly. And so from that point of view, you might not be in condition to satisfy them, right? So from that point of view, the perception can be negative, irrespective of how good willing the parents, of how good the parents try to be, right? Anyway, this perception can be either positive, and in this case, we say that there is secure attachment, and this is roughly 60% of the overall population in the world, or it can be insecure, and this corresponds to roughly 40% of the population. Now, when I see 60-40, it's interesting. This has been measured in many different countries in the world, from very rich countries to very poor countries. It has been measured in many different socioeconomic contexts, from very rich people to very poor people. And funnily enough, interestingly enough, these percentages remain, these proportions remain, right? So you can see that insecure attachment is something that concerns 40% of the population. So from this point of view, it's not a pathology, but it's some kind of predisposition to a number of problems. For example, when you go to juvenile prisons, so for people between 15, 18, etc., if you got the people that are there, 90% of them turn out to have insecure attachment. Another interesting thing, a lot of people that have coronary pathologies, right? You go to see and they are insecure. Why? When you have insecure attachment, even as an adult, you tend to have a negative perception of all relationship in life. This increases your stress, and so somewhat your coronary system, your heart, is put under major pressure, and so you are more likely to develop this type of pathology. Same thing, for example, for antisocial behavior. You go to see all the people that manifest antisocial behavior, you measure their attachment, and you see that 90% of the cases, they are people with insecure attachment. So not all the people with insecure attachment end up experiencing those problems, but a large fraction of the people experiencing those problems turn out to be people with insecure attachment. Now, what can we do to try to address this problem? You should try to detect insecure attachment as early as possible in life. So, what is important is trying to analyze children and detect insecure children as early as possible so that you can do something in order to help, in order to ensure that all the problems related to insecure attachment become less likely. Now, what is the problem here? The problem is that assessing the attachment condition of a child takes a lot of time and correspondingly a lot of money, because you need professionals to do that, right? To give you an idea, one of the most common tests used by psychiatrists to assess the attachment of a child is the MCAST, which stands for Manchester Child Attachment Story Task. And the way it works is that psychiatrists deliver to children a number of story steps, right? For example, you wake up in the middle of the night, you have a nightmare, right? And you call for your parents. What does it happen? And then they ask you to continue the story, and they give 2 dolls. And what the doctors do is that they somewhat listen to the children, they record the children while they deliver the continuation of the story, then they go through the recordings, and based on what the children say and how they say it, they basically assess, they decide whether the child is secure or insecure. Now, this takes a lot of time. So what we try to do is to automate it, and we put together an automatic system that delivers this test while recording the child. So there is a screen where an actor delivers, so it is simply a recording. So the children, the participant, can basically see an actor telling the story. You wake up at night, or it is breakfast, you call for your parents for breakfast, what does it happen, etc. Then there are a couple of dolls, one that represents a caregiver, so we call it mommy doll. The other is a child, so baby doll. Then there is a playmat that shows an apartment. There are little furnitures, little tables, little bed, etc., so that you can put the story in an apartment fundamentally. And of course, there is a camera that records the child while she or he is undergoing the test. And the idea here is to see, of course, whether we can automatically identify children that are insecure, that have insecure attachment. So once again, you see exactly like we did before, because more or less the method is the same. We collected data. So we went through multiple schools. We collected data for 104 children. They are distributed across multiple school levels of the primary school in Scotland. So P1 to P4 stands for primary 1 to primary 4. You can see the age range. Primary 1 is 5-6 years. Primary 4 is 8-9 years. And you have everything in between. And you can see how these children are distributed in terms of gender and in terms of attachment condition. Of course, we have some psychiatrists, some people trained to assess the attachment condition of children, in order to give us an assessment of the attachment condition, right? So when we say secure and insecure, is the assessment of 4 experts that we involved in this experiment. And the sample is representative more or less of the population, because we got roughly 60% people with secure attachment and 40% with insecure attachment. And then this is to give you an idea. There is not just one story stem, there are 5. Each of the story stems try to reproduce a mildly stressful situation. So breakfast, okay, you wake up in the morning, you are hungry, you want to have your breakfast, etc., and let's see what happens. Nightmare, okay, is about fear, the nightmare in the middle of the night. Hopscotch is about having an accident while playing. Hopscotch is a kind of physical game that children can do, right? And it can happen that someone falls and hurt their knees, etc. So nowadays they mostly use soccer, because hopscotch is probably no longer something that children play with, right? However, it is about physical pain. Tummy ache, again, is physical pain, is the child having. And shopping mall is a story about a child losing contact with parents in a shopping mall, right? And you can see what is the average length of the continuation of the stories of the children. So how much time children talk about a story before they conclude it. And you can see that breakfast and shopping mall are the longest stories, very probably because these are experiences that are more frequent than the others, right? Luckily enough, it happens more frequently to have breakfast or to go to the shopping mall, which is something that probably they can imagine better, right, than having nightmares or having accident at game or having tummy ache, right? So probably this is why we see this uneven distribution of time across the story stems. And the approach we use, fundamentally, it is, well, for what concerns paralanguage, we use stacked recurrent neural networks. We convert audio into a sequence of feature vectors. Then we pass it to this model that gives us as output a posterior probability of the child being insecure. And we do this for all the 5 stories. And then we use a weighted average to decide whether the child is secure or insecure. And these are the results that we get, right? we get the results. I can show the results both for the individual stories and for the weighted average of them, right? What you get when you take into account all the stories. You can see we are roughly around 65, 66 for the best results. And when we combine all the stories, we get up to 69%, right? Which essentially, what happens is that the reason why you have multiple stories is that every child will be sensitive to different types of negative experiences. So they will show attachment-relevant behaviors for some stories, but not for others. So by doing a combination, you expect that if in at least one the child has shown insecure attachment, you can see it. And actually, you can see that here, the combination of all the stories gets something better than the best individual stories, right? 69% is better than 65.8 to a statistically significant extent. Now, what do we do for the text? Well, more or less it's the same thing. In this case, the transcription is not manual, it is automatic. It was done with Whisper, which is a very powerful speech recognizer. Then we use Word2Vec in order to convert all the words into vectors. So once again, we have a sequence of vectors. We pass it to the same approach for what concern the attribution to the two classes. We get once again posterior for individual stories, and then a weighted average in order to decide whether the child is secure or insecure. So you can see that very lazily we have tried to do exactly the same thing, but this time using a sequence of vectors that comes out from a text rather than from audio. And these are the results that we get. You can see that we get a little bit better, right? We reach 70%, which is something that didn't happen earlier. However, in this case, for example, combining all the stories doesn't improve with respect to the best individual stories, right? So very probably language, from the point of view, in the terms of language, probably we don't manage to really see a difference across stories. More or less, the stories are always the same, right? What children tell is the same. So probably the channel that conveys a bit more information from this point of view is audio, because it tells a bit more about the emotional content. And from that point of view, somewhat it seems that in this case, the combination of multiple stories doesn't really help, right? And then what happens? Well, we have two unimodal approaches, one based on language, the other based on paralanguage. Let's try to combine them. And what we do is simply, at the end, we have 5 posterior for paralanguage. We have 5 posteriors for text, for the transcription. We simply apply a weighted average so that fundamentally we can combine, we can have a multimodal combination of the two, right? And in this way, we take into account both what children say and how they say it. And once again, we can do this story by story, and then we can do this by simply using, again, the weighted average over all possible stories. So we combine story by story the two modalities, and then we combine the output of the multimodal approach across all stories, right? And these are the results that we get. Once again, it is something we get a little bit more. So in this case as well, we get an improvement compared to the unimodal approach. And in particular, when we combine all the stories, we get something that not only improves over the best unimodal approaches, but also improve over the use of any individual story, right? Which is good because it means you don't have to do something to select a particular story in order to somewhat get a good result, right? That will be complicated to do. Now, just to give a better sense of how this goes, this is the performance in terms of accuracy and F1 score for paralanguage, the best we get for paralanguage, for language, and for multimodal. And you can see actually how we go up and how the multimodal approach decides correctly 3 times out of 4, which is not that bad given the complexity of the problem. And somewhat you can see that it keeps going up when we go from paralanguage to multimodal. Now, to give you an idea, something that is very important here, we go from children that are 5 years old to children that are 9 years old across the multiple school level. And somewhat we can see that the performance tends to be better in the two intermediate level, P2 and P3. Now, a statistical test tells us that there is no difference between these various numbers. But probably that might be a consequence of the fact that we have less children in P1 and P4 than now we have in P2 and P3. However, if we have to try to give some kind of explanation, I can tell you that really anecdotically, children in P1, sometimes they're really too young. They don't really manage to do it. So there is a failure because they're probably too young to play the test. Children in P4, they start saying, you know, I'm too much of an adult to play with dolls. So sometimes they don't really engage with the system because they feel they are no longer children, that dolls are no longer toys that are appropriated for them, right? However, it was important to do this type of test because from 5 to 9, you have really a large number of developmental stages. Clearly, 4 years are not a lot if you say 50 to 54, but 5 to 9, I mean, it's usually one of the two has lived twice as much than the other and has developed from a cognitive point of view much more than the other, right? So it was important to see that actually the performance remains relatively stable across the multiple levels. Now, one important question now is whether somewhat this is good enough. You remember more or less the same a question we posed earlier when we came with the confidence score. Can we use this? Is this something that in practice potentially is of use? Well, what we did, it was to take 60 children and to make them pass not only through this test, but also to the traditional MCAST, the one where there are the psychiatrists and let's say they don't do it with the automatic system, they do it the traditional way, and to see whether the automatic approach was basically giving the same decision as the psychiatrist going to the traditional way, and the degree of agreement between the automatic approach and the real psychiatrist doing their job was sufficient for the system to be considered an acceptable tool, right? So in general, when a junior doctor joins a group, is tested in the sense that in parallel they do a diagnosis, both the junior doctor and the more senior doctors. When the degree of agreement is above a certain threshold, then the junior doctors is allowed to do diagnosis on their own because they are considered sufficiently prepared. Well, the system basically was performing above that threshold. So from that point of view, if the system was a junior doctor, will be actually accepted as a person that can do diagnosis in a hospital, right? So from this point of view, once again, we managed to produce more or less at the level, if not of the most expert doctors, for sure at the level of the most junior doctors. So this was another example to show you that this type of approach, this type of way of thinking about mental health works not only for depression, but potentially can be extended to any other pathology that leaves traces in the way people behave, in particular in our case, in what people say and how they say it, because you have seen that in both cases it was about language and paralanguage, right? So from this point of view, actually, that's where AI can actually help with mental health. So a few words of conclusion, what I want to do, given that somewhat I understand this initiative is also very much oriented towards younger people that maybe are at the beginning of their career. It was to somewhat highlight a little bit for those who might be interested in entering this field, what can be some interesting challenges to address, right? Well, besides the methodological challenges, these are very challenging data, so those who are oriented methodologically can really try to elaborate very, very sophisticated, very complex models. But I think where really the challenge is in using this thing, is a little bit in bridging the gap between the laboratory where we do our experiments and somewhat the use of these models, right? And first is closing the usability loop. So the way I've been talking about this system is something that people that are technologically prepared can understand. Percentage, accuracy, F1, confidence score, etc. However, you cannot necessarily expect that a psychiatrist understand that type of language, right? So one important point is to make them usable for a doctor that can be an excellent psychiatrist, but doesn't necessarily know about artificial intelligence and how it works. Another important thing, very important, is empowering clinical users. So you can see that I never use the word diagnosis for these approaches. And the reason is that we should never leave the diagnosis to an automatic system. It has to be the doctor that decides, right? So essentially, these systems have to be designed to provide information that supports the diagnosis process, but the diagnosis has to be made by a human, right? Another thing is bridging the interdisciplinary gap. This is for whoever collaborates with people in other disciplines. So Nico has mentioned that actually I like and I tend to collaborate a lot with psychologists, psychiatrists, sociologists, etc. It's something I like to do. And typically the point is always, well, you have to inform people in those domains enough for them to understand enough how an AI system works, if they really want to benefit of it. And in turn, I mean, you have to try to take into account how these other domains work in order to develop good systems that can work in this type of context. And this is often something quite challenging. And finally, the availability of useful data. Sorry. This means, in very simple terms, you know, that data plays an important role, and it is really important that we manage to collect enough data, but also means that you have to pay attention to apply this type of technologies only when they can work. I've shown two examples where the pathologists really leave traces in the data we are analyzing, but it is very important that before you trust the outcome of AI, you are sure that what you get are actually the traces of the pathologies you are addressing, right? So from this point of view, it's always important, and this is where interdisciplinary collaboration can work, that you are sure that what you are detecting is really the pathology. Thank you very much, and I'm ready for your questions. Thank you.
Thank you, Alessandro. Really, really nice. Very, very nice, as usual. People, if you want to ask questions, so just please write it in chat or just ask them directly. You can also raise your hand and you can promote yourself. Well, I will start with Attila Elsi. Maybe you want to ask a question directly to Alessandro.
Hi.
Hi.
Hello. Hello.
I wrote my question to chat box, but that if you want to read it, I'll tell it verbally.
Yes.
Yeah. The way I'm used to seeing figures in terms of applying artificial intelligence methods to real cases, we talk of somewhere around 80–90%, but the figures here are nowhere there.
Yeah.
The best is 76%. Why is this so? Is there language barriers? Is there understanding barriers? Could you comment?
Sure. So the big issue here is the very ambiguity of psychiatry and psychiatric problems, right? So unlike normal diseases, right, that leave physiological traces. So for example, if my blood pressure goes above a certain level, we can have some ambiguity whether the threshold is here or there, etc. But when it is above a certain level, all the doctors can agree that there is a problem there. When it comes to problems like depression, schizophrenia, attachment, etc., there is an inherent ambiguity. It's a lot about interpretation. And to give you an idea, in the case of attachment, I mentioned the story of the junior doctors that when they join a hospital, they basically start making diagnoses in parallel with the most established doctors, and they are tested on how well they replicate the judgment of the doctor. You are considered acceptable as a junior doctor, meaning that they let you do a diagnosis on your own. If you are at 60%, of the senior doctors, right? When you think about 60%, it's really, we are close to chance level. So the real point, not only, but funnily enough, the depression data that I used were collected in Southern Italy. When sometimes here I play that data here to British psychiatrists, they tell me none of these people is depressed. Because really from a cultural point of view, the way the level of expression, even the level of activation, even of the most depressed people, is such that here in the UK will say, no, this person cannot be depressed, right? So you have an enormous ambiguity. The very way patients express their pathology changes from country to country according to social norms, etc., and so on. And so from that point of view, that's where these relatively low scores come from. It's really that there is a lot of bias. Not only, but for example, it's well known, right? When a woman goes to a GP and says, I have a certain pain, disease, etc., something that doesn't go, physiologically, the doctors are 3 times more inclined to think that there is a mental issue, right? That is a kind of somatic type of disease, than in the case of men. So this is where there is this enormous ambiguity. So you take multiple doctors themselves, and the level of agreement sometimes is very low, right? So this, I think, is particularly interesting in this data, but that's also why, presumably, we will never really get very high accuracies, right? Because the ground truth, so to speak, is very shaky, right? I don't know if I answered the question.
Yes, indeed. Thank you.
Thank you.
Well, the sample data you uses ground truth as medical professionals' findings.
Yeah.
So you could do as good as that, because your data is based on. But maybe we would need better methods to
that's for sure.
To judge.
That's for sure. Thank you.
Okay, there is Saifuddin Kadri. You can ask your question.
Yeah, thank you so much, Professor, for the presentation. Just a couple of questions. When you compare different techniques in one of the slides, different algorithms, did you calculate the significant and the p-value between these different algorithms?
Yes, all the times. Yeah.
Okay, and so I noticed one of your study somehow the sample is low, and the question here, because I think you have 60 patients. So when you're saying about moving this application to the clinical in order to have the clinician. So when you decide, because now we are talking about something very critical related to health and to mental health. And I didn't see in the presentation you talk about generalization of your study.
Yes. So this is the reason why I use this sample of 60 people is essentially because we have the linguist translating it, transcribing it automatically. So that gave us a chance to have a particularly detailed study about individual. Since then, we have collected much more data. Now we have a study with 120 people. And somewhat, by the way, this data set is also available to everybody. This is a critical problem, etc., of the domain, right? There are a few corpora around, but if we put together all the publicly available corpora, we have no more, I would say, that 500 participants in total. Keeping in mind that, for example, this one and let's say the larger data set with 120 people, we ask psychiatrists to do the depression diagnosis. So in a sense, we are trying to reproduce what doctors do. Another important data set is called AVEC, Audiovisual Emotion Challenge, because it was used in a challenge, I think, in ACM Multimedia. For example, what they ask is to people is to fill the back depression inventory that, you can see how ambiguous it is. So it is a self-assessment. Not all the people really do it honestly, in the sense that sometimes really you try, a lot of depressed people try to escape diagnosis, right? Because they want to be treated, they don't want to get the stigma associated. So not even that all this data has not been collected always with the same protocol, and it's not always the same task. So in my case, it's really depression detection. In other cases, it is the prediction of the score, or at least of the various categories associated to the score. So generalization is a big issue in all these domains, right? And when you try to extend to more general use, we try to work, for example, with the government here in Scotland to do automatic attachment assessment to all children in school, at least to have an indication, not even really for medical purposes. It was essentially to measure, for example, whether there were areas more likely to bring to insecure attachment. Some of the government told us, no, we will never allow you to use methods of this type because, AI with children, forget about, right? So you can see it's extremely complicated. So it's clearly an issue. For the moment, the best we can do is to put our data at disposition, to give rigorous protocols, and at least to make comparable the approaches. How this can generalize to use then, I think it's the next probably decade will be when we will start trying to use it and see whether the use can lead us anywhere. I believe a lot in things like confidence score, helping trying to create a team, AI plus doctor, and measure the performance of the team. I'm trying now to use this and see how the doctors make sense of the outcome. And now they learn after they see it a little bit, say, no, here it makes a mistake. And it does it because you see blah, blah, blah. So they learn to make sense, and the joint performance, it's higher actually, right?
Okay.
So that's why if you notice, all the challenges I see are about using them, right? Because we have that problem.
So, but sorry. I mean, in your team, for example, in this paper, so we have 3 authors. Is there any one of them a psychologist or psychiatric, or you work in parallel with some?
The central author, Anna Esposito, right? She's in a department of psychology, and she's our contact.
Okay.
And where you need the psychiatrist, the data collection, where they really help a lot.
Okay, my last question, if you allow me. So in your opinion and experience, because now we are using AI to help the medical field and to help in some diagnostic, but what is your view on AI before that problem happened and after? I mean, before the person get depressed, can AI help? And after the person get depressed, what AI can do for this person? And thank you so much.
Sure. Before, let's say, the attempt is to there are studies in trying to get diagnosis as early as possible, right? Because the earlier you intervene and the better it is. This applies in particular to cognitive degeneration. If you relate it to age, if you get it early, then you can intervene, right? So that is where before it is something that can help. After, what I see around happening, and it's probably a good thing, is, for example, in some cases at least, sometimes what a depressed person or a person in general affected by mental health issues, sometimes you just need very little intervention, right? So there are a lot of people that are trying to do something called cognitive behavioral therapy, which simply means I give you 2-3 suggestions that help you to get out of your inner loop, right? So a lot of attempts are to try to assess automatically whether that can be sufficient, and then give a little automatically generated suggestion that can help the people to get out of what is not a crisis, it's just a little down, right? So these are the 2 main things that I see happening right now. And I hope I answer the question.
There is a question from Matthew Butler.
Hi there. Yeah, thanks. It's an excellent presentation and very interested in your work. So I just had a couple of sort of points to make. I'm sure you're probably aware, but there's a big data set at the Institute of Psychiatry in terms of a natural language data set where the data are validated. It comes from electronic patient record systems across the NHS, across mental health services. So I don't know if you use that at all. It's through the something called the Case Register Interactive Search System at the Biomedical Research Centre at King's. So they will have diagnoses in them that are set against different clinical observations of patients. So that could, play a role. Did you use that at all? Or?
I didn't use it. The reason is, as far as I understand, there is only text in there.
It is. No, well, it's text, but it's data as well, because so there is, it captures a structured diagnosis, the ICD-10 diagnosis, and there's also outcomes measures in there. So things like if you're looking at depression, I don't think it's got the BDI, but it would have other measures, standardized psychiatric measures of depression, and things like the BPRS, brief psychiatric rating scale, things like that, a PHQ-9, primary care measures of depression. So it's got a lot of outcomes measures in there as well.
It's very interesting. Let's say it's a bit of a different work, so I didn't have a chance to use it. I didn't use it, but no, definitely is an important resource. And yes, absolutely.
And the other thing, so you just mentioned, was around therapies. Have you looked at therapies? Because diagnosis is one side of it, but obviously providing therapies is key. And CBT is a very structured approach to therapy. So again, you could use some kind of natural language processing to develop applications along that way. And it would be great to see this kind of thing once it's been sort of further built up to actually see this in electronic patient record systems as a clinical decision support tool for clinicians. If such a thing is
no, that's very interesting. I didn't do it, right? Let's say that the diagnosis is a kind of bottleneck. I didn't mention it, right? But there is an estimate that roughly half of the depression cases, and in general, half of the mental health cases, go undiagnosed. Because sometimes, people don't even realize something like that exists, right? It is relatively recently that there is a lot of awareness about the problem, but until a few years ago, people were not even totally aware. Often, if there is not a family around, the person is not even brought to a doctor because, a depressed person doesn't even find the motivation or the energy to go to a doctor. A lot of people try to escape diagnosis anyway, because still depression, mental health is associated a bit to a stigma. And plus, in many countries, mental health services are underfunded. So there are not enough doctors and services, etc. So the reason why I concentrated a lot on this, because my aspiration, etc., my idea, where I think it can be interesting, is to increase the efficiency of these services so that with the same amount of funding, you can screen a lot more people and potentially detect more cases. So it was mentioned earlier, the accuracies are lower, etc. But when you go to compare to the number of cases detected now, to the fraction of cases detected now, still there will be an improvement in terms of chances of a person affected by a problem being diagnosed and then being treated and then getting appropriate medical attention, right? And from that point of view, really, because it's a literal tsunami that is now challenging the mental healthcare services around the world. Not to mention in the poor countries where sometimes these services are simply missing at all entirely.
So, I guess you're familiar with the IAPT program, Improving Access to Psychological Therapies. So they made a case in the UK, a guy from the LSE, London School of Economics, alongside one of the professors of psychology, that said that CBT, investing in CBT, pays for itself, more than pays for itself. So because you get, more increased economic participation.
Yeah, absolutely.
Okay, well, so one last question just to finish. This is well, what you already did, Alessandro, like social signal processing. So some Hadi is asking if there been any attempts to use visual cues for training a model, like observing the body language of patients.
Yes. There has been a lot of work. I mentioned this data set, AVEC, AVEC. In that case, you have a recording of the person filling the BDI questionnaire, so you can see the body, you can see the face. Facial expressions are particularly important. The reason why we didn't do it here is that a lot of people with depression refuse to be recorded. So initially we wanted to go for that. There are RTs with simply a microphone, etc., but staying in front of a camera is really not something. Well, you have seen that in the case we didn't use it actually for attachment. We didn't use it yet. In that case, the children were more happy to be recorded. For example, they liked it a lot to see their videos after, right? So it's really a problem also sometimes of the approach being accepted by the very people is supposed to be beneficial, right? But yes, absolutely, it will help a lot.
Okay, let's see. Okay, yeah, thanks. Well, let's stop here. I think it's very fascinating, Alessandro. So we can keep you here for another hour or so just to answering questions. Well, thanks a lot for talking to us. I think it's quite inspiring to look into this, and it's of course has a lot of impact as illustrated by all the questions and everything. So, okay. Thanks for your talk, and guys, thanks for being present.
Thank you very much. Thank you very much, everybody.
I hope to see you soon, Ale.
See you soon. Yes.
See you guys.
Thanks.
Bye. Thanks.
Bye.
Bye.